Hey, everybody. Can your internal organs actually fall out? Find out on our upcoming episode with Dr. Rebecca Lane, a urogynecologist, on Gross Anatomy. Welcome to Gross Anatomy, everybody, where we explore the sights, smells, and sounds of medicine, how it relates to movies, TV, books, podcasts, and the world around us. And I am Dr. Jason Cohen.
Taylor.
Who do we got today, Lauren Taylor?
Today we are joined by a very special guest. We've had a gynecologist on before. We've had a urologist, but we never had a urogynecologist on before. So we're very happy to have our guest, Dr. Rebecca Lane, on today.
Yeah.
Well, thanks for having me.
When did I meet you? What year? When did you come out to... You were a brand new attending, right, when I met you?
Yeah, probably. So that would have been too long ago, 17 years ago, 2008.
Wow. I've known you for 17 years. I want to let you know that I want to let everybody who's listening know, all 70,000 listeners, that I wanted to recruit you to our group. And I must have multiple times said, join our group, join our group, join our group. And you just never joined our group. You could still, it's never too late though. You could still join our group.
Still on the table? What's going on with your group?
What's that?
What's going on with your group?
Our group is good. We're growing by leaps and bounds, and we could use a urogynecologist. Talk to us. Tell us, Lauren Taylor, what do we want to ask this urogyne? Like, people don't even know that there's such thing as a urogynecologist. What the heck is a urogynecologist?
So my background is OBGYN. Like, I did an OBGYN residency, and then my subspecialty training was a 3-year fellowship in urogynecology. People can also come to it from urology background and do the same fellowship. But it's all things related to pelvic floor disorders. So as a urogynecologist, people get referred to me if they have issues of urinary incontinence, pelvic organ prolapse, recurrent bladder infections, painful sex, just
really sexy stuff, really sexy, good stuff.
Stuff that people love to talk about, feel very comfortable, sharing with everybody.
You find people people don't like to talk about that.
No, I'm being sarcastic. I feel like I'm the best kept secret, unfortunately. People really do not even like to bring this stuff up to their primary care physician, even to their OBGYN, sadly, I see patients every day who've been suffering silently with a very treatable condition, maybe, leaking urine, because they didn't think there was anything to be done about it. So thanks for getting it out there on this podcast tonight.
Yeah.
So I was very excited to have you on because I don't feel like I personally hear women talk about any of this stuff. So I was wondering if you could get more into one thing that you brought up, pelvic organ prolapse. Can you explain what that is?
Sure. So the pelvic floor is kind of the bony pelvis, and there's basically like a hammock that's created by muscles and connective tissues, and in that sits basically the bladder, the uterus and vagina, and from front to back, bladder, uterus, vagina, and then in back is the rectum. And so as a result of genetic predisposition, pregnancy, childbirth, obesity, chronic cough, things like that, the muscles and the connective tissues can get weak, and then any of those organs can kind of herniate through. So it's a type of hernia.
What does hernia mean?
You tell us, Dr. Jason. It's bulging down through the pelvic floor. So the result is, women will come to me and say, I feel this tissue bulging out. It's like an egg. It's like a golf ball. So it feels like pressure, and you might even see or feel something coming out. And I think women get really freaked out and scared that something's literally going to fall and detach from their body, which is not, that can't happen, but it is, not gravity has kind of pulled it down. It's not in the position that it was intended to be in. And that can lead to, the bladder not emptying properly, or the bowels not emptying properly, or just feeling discomfort.
Someone could actually come in with their uterus half out of them.
Yeah. Mm-hmm. Sure.
How often do you see that? How common is that?
It's a lot of what I see, actually. I see it a lot, because it's kind of a gradual thing, but it doesn't really become symptomatic until it actually comes out beyond the vaginal opening. And then suddenly they're like, where did this come from? What's happening? So, I think it's being talked about more now. And certainly one thing that a big peak is I see women in the postpartum period is a very common time when these symptoms first kind of appear, and then things will heal themselves, go back to normal, but around the time of perimenopause, they tend to come back again. So those are the two kind of main peak ages where women are coming in with these issues.
No, that's terrifying. And I'm glad we're talking about it. I'm glad other people are talking about it because, I feel like a lot of women wouldn't know what to do or would think it was some kind of tumor or cancer. I don't know. I mean, I imagine.
Yeah, they really do find it scary and alarming. And I think the important thing is to know that there are treatment options available. And some are surgical, but there's also non-surgical options. So women should know there is a point in, bringing it up to your provider, and there are things that can be done about it.
What a surgical option is, you actually remove the uterus, or are there other surgical options too?
Yeah, typically we remove the uterus, but the main goal of surgery is to resuspend, kind of replace the connective tissue that has been damaged or the ligaments that have been overstretched. And so a lot of times that involves using, a permanent mesh to kind of anchor up the vaginal walls to some strong ligaments in the pelvis, basically.
And you do that with scopes and cameras usually, or laparoscopic or robotic?
Yeah. I mean, there's a lot of surgeries that can be done vaginally as well, but typically the gold standard treatment that we do is called sacral colpopexy, and it's done, either laparoscopically or robotically.
There's one OR nurse who always jokes around with me when we were, I'm changing the topic urogyne a little bit, but she had just had a baby. She's fairly young, had just had a baby, and I said or did something funny, and for a long time I thought she was joking, but she's like, I peed all over myself, she said. And I thought the first time, and now it's like 10 years later, and now she's like tells everybody the story, how she, was cracking up and wound up peeing all over herself.
Well, I hope you gave her my card.
You know what? I think she's better. I have no idea, but you know what? I'm going to go find her and give her your card. How common is that after, that's really common, isn't it? Like crazy common.
Quite common. Like urinary incontinence affects more than half of women. There's two types of urinary incontinence. So the type you described, like that's associated with laughing, coughing, jumping, sneezing, exercising, that's called stress incontinence. And that is, again, related to pelvic floor weakness, very common after childbirth, but also present in women who've never been pregnant. The other type of incontinence is urgency incontinence. So like you have the urge to go. Sometimes it happens like right when you're opening the door to the house or the garage door, and suddenly you can't hold it anymore. So that's urgency incontinence. And that one gets more common with age, and women are waking up at night to go pee. Both types are very, very treatable. Urge incontinence we treat typically with medications. If medications don't work, I mean, one thing that I love so much about my field, I have to say, is 17 years ago when we first met, I think I only had medications to offer patients who had this kind of leakage. And now we also do Botox injections in the bladder, kind of, calms down that bladder muscle so it's not spasming. There's nerve stimulators that can be implanted. There's nerve stimulation that they can do in the office, and even tibial nerve, like leg nerve stimulation that can be done at home. So we're just have a lot more to offer patients, which is really great.
If you have like incontinence, what do you have to go see someone? Like, is that something that does it
No.
harm you to go to the bathroom a lot? Like, I keep seeing in my newsfeed like when you should be concerned about how many times you go to the bathroom, and I never know if any of it's true or not.
That's such a great question, actually. No, I think one of the things I like a lot about my field is it's women are healthy. It's not, like having cancer. It's quality of life stuff. And I always tell my patients, like, if it doesn't bother you, it doesn't bother me. Like, it's not great to wake up, 4 or 5 times at night. That's not great for your functioning and if you're working, but none of it is dangerous.
Okay. I guess that was my question. So thanks.
Yeah.
One of the diseases, one of the surgeries I like to do the most is parathyroid surgery. And, there's certain absolute reasons why we do parathyroid surgery, but then anecdotally, when you talk to patients, and I'm wondering if you've seen it at all, one of the side effects of being hyperparathyroid is having to pee a lot and pee all the time. Have you encountered that at all as differential in some of your patients?
Super rarely. I mean, because what I see is it's so classic and common, but now I'm going to see it probably tomorrow because you brought it up. But no, I think we often have patients do, like a bladder diary and record the volume of urine. But I think what we're talking about more is frequent voids of small volumes. It's just the bladder's inability to hold.
So you actually inject Botox sometimes into the bladder?
Yeah. So we go in with a scope through the
Uh-huh.
urethra.
Okay. With the patient
Then
awake or asleep?
quick.
Awake. I want you to know if anybody's doing anything to my bladder, I have to be asleep.
Okay.
Do you always like? What if like I don't like I talk to my urology friends and they're like, yeah, I do it. I'm like, and I talk to friends or people I know who are having a vasectomy and they're like, we're doing that away. I'm like, what? You,
They let me do, when I was a third year medical student, they let me do a vasectomy on an awake man. And I don't know if I was more traumatized or he was more traumatized.
yeah.
um,
So you do it awake.
we do it awake. Like I instill lidocaine into the bladder, and it's probably like Botox that a lot of women get in their face. Like it's not comfortable, but
Yeah,
it's
I would
not.
have to be asleep for that also, though. That's the
Oh
thing.
well,
I'm a total
you're
wimp.
just
Actually,
you're just right.
my wife wants to give me Botox in my forehead, and I'm like, I'm a wimp. I'm a total wimp. Women are much tougher and braver than men, I think,
I mean, yeah,
in general.
Yeah.
Seriously.
absolutely.
True,
Yeah.
but like I learned from Bernice, your wife, the master injector. She told us all about Botox and how great it was. So now I want some just like for my headaches or, different
Yeah.
things. But I didn't know it was used for in the bladder like that. That's amazing. Like it seems like there's nothing it can't do.
Yeah, no,
So,
it's really
so how
fantastic.
does it work? How do you do it exactly?
You go in with the scope and through the urethra, and then typically we do 10 little injections, although now there's data we can do even like fewer injections and
Into the wall of the bladder.
into the wall of the bladder muscle. Yeah.
And there's a needle injector through the scope. I've never, it's so funny as doctors, we don't have any good cross hanging out to see what each other
No,
does. It's
I
really
know
unfortunate.
we really are very like siloed in our own specialties. But yeah, there's like a super long, I mean, it's basically a small needle at the tip and it passes all the way through the scope and you just bury it like a millimeter and just do the
And
little
is
pokes.
that something you have to keep doing like you would do for okay.
Exactly. So typically it lasts anywhere between 6 and 12 months, and then you do have to repeat it. But unlike the cosmetic Botox, it's covered by insurance.
Oh, wow. That's great.
Yeah. So to your question about, do you have to come in? Like, no, you don't. So it's quality of life stuff, but it's still covered by insurance.
And that's to treat someone who finds that they have to pee all the time, kind of thing.
Yeah, exactly. Because what's happening is, um, you know, the it's bladder spasms, to kind of simplify.
I
But
think I have that. I think I need that. I think I'll let my wife know. I'm not, but I
have her
do. I think
start
I
with the
have.
face, see if you can handle that.
I have to pee all the time. That must be me. I don't think it's a prostate thing. Do I need Botox in my bladder?
Maybe
Maybe I'm getting
you could do
nervous.
that all live on the podcast.
That could, we actually filmed my colonoscopy a few years ago. We had, and we put it on my Instagram. So that would be something.
Yeah.
But I definitely would not be. There's no way I could be awake for it though. So say plastic surgeons are do Botox and all that, or injectors or derms. Do they ever veer into your field? Like, is there any kind of crossover? Like, would my wife ever be like, yeah, I'll do it into someone's bladder? Because she's pretty bold in terms of what she's willing to do.
I've never heard of that because I doubt that she has a cystoscope and that
Right,
equipment and that
right.
comfort of knowing, to avoid the trigone. And I don't think so. But, you know, labiaplasties, and there's now no joke about kind of that we've been inspired by the dermatology world. There's vaginal lasers and radio frequency treatments, and a lot of them are really quite effective. And I do see a lot of cosmetic people offering those at, med spas and whatever.
Would that be within the realm of what a urogynecologist does too, a little bit?
Yeah, no, for sure. I offer that. That's another option that's um, actually remarkably effective for treating a lot of urogyne things. It treats vaginal dryness, the urinary urgency, frequency, even the stress incontinence. It's the success rates are not huge. We don't have a lot of data on it, but people really love it because it's easy, it's painless, it's no downtime, it's in the office. It's
Yeah. I
it's
I have a friend who years ago, and I wonder if you've seen it in women too. Years ago, stopped being able to pee.
yeah,
And now this friend has to catheterize himself
yeah.
um, for the rest of his life. He catheterizes himself. Does that happen just as much? It seems pretty rare, and that happens in women too, where they have to catheterize themselves.
Yeah, definitely. I mean, if it's it can be a neurologic cause. In women, sometimes they can't empty because of prolapse. Like if the bladder is dropped and it kind of kinks the urethra, in that case, we can fix it by lifting up the prolapse. But yeah, if there are women for sure who can't empty, and the risk is, the urine can back up to the ureters and the kidneys, and it can increase your risk of bladder infection. So yeah, I do teach women how to self-catheterize.
Wow, that's it. As a young guy, who's been doing this for years, and it's just so interesting. I think there is. I don't know how effective it is, but there's a right? A stim that you could try. What is
Yeah,
what is what is?
that's the same nerve stimulator. It's like a sacral nerve stimulator that we can implant. It's interestingly, we don't know exactly how it works because it works for both the urinary urgency frequency and also for, the inability to void, but it's stimulating the nerve.
Interestingly, not a lot, but some of this stuff is also, two of my partners are colorectal surgeons. So if a patient has vaginal prolapse or uterine prolapse, it's often associated with a rectal prolapse too, right?
Yeah, they commonly go together.
Yeah. So I know they do those surgeries, and often it's in tandem with urogyne or gyno-uro, right? Urogyne, basically.
Same, yeah. Hmm.
Yeah. Uh, but you don't do the like it's very stay in your lane kind of thing, right? You wouldn't, and thus Rebecca Lane.
Yeah, yeah.
Nice.
So I have a question going back to incontinence. Is there like any exercises, non-surgical stuff that you could do to improve it?
Yes. Yeah, no, I think that's really important for prevention and also for treatment. Pelvic floor physical therapy is very, very effective at treating all types of urinary incontinence and prolapse. So strengthening those muscles is effective and important. But it is, not everyone needs to do Kegels, because on the other extreme, I do see women who come in for painful urination, or pain with sex, and in those cases sometimes the muscles are overly tight. So and those people have to go see a physical therapist to help kind of loosen and relax those muscles.
Okay. So they would actually have to go see a physical therapist. That would be your recommendation to
Pelvic floor physical therapist. Yeah. I mean, I send a lot of my patients to work with pelvic floor physical therapy.
Is it more than just Kegels, or is there more to it than just squeezing your sphincter?
So strengthening the pelvic floor is basically doing Kegels, but the idea is what people don't realize, like you want to hold that contraction for 10 seconds and then relax for 10 seconds, and you have to do 10 reps like that maybe twice a day. So it's a
I
whole
have a
workout.
weird question. Is it good? Like, say you have to pee. Is there like an advantage to saying, let me hold it for as long as possible to like, is that a good
Yes.
thing, bad thing, or neither?
That's a good thing. So it's like retraining your bladder, because if you go pee every time you feel the urge, like it's a fallacy that, you're going to get a UTI by holding it too long. I think a lot of
Right.
women are told that. It's good to hold it. You want your bladder to be able to hold more. Otherwise, it's just going to get used to being empty.
Would that help that spasm thing potentially, or that's totally different pathology?
Yeah, no, you can help it by retraining it, by just saying like, yeah, I feel that urge and I'm going to ignore it and keep holding it. And you kind of, it's neurotransmitters that are being sent down from the brain to the bladder. So you kind of, if you can reestablish that control at a higher level rather than just having the bladder off doing its own thing.
I got to start doing that, I think.
Well, I was wondering, because
And
you're
drink
both
less
surgeons,
coffee.
Yeah, I know.
but you're both surgeons, so you must kind of have those neurotransmitters. Like you don't pee during surgery, do you? Or can you?
You
Dr.
can.
You gotta pee, right?
You can? Okay.
Yeah, but they catheterize us during surgery. No, I'm just kidding.
I have heard stories of maybe it's just on TV, where someone will catheterize themselves so they don't have to scrub out. But
You think
I think it's urban legend kind of thing.
Yeah.
Yeah, that I've never heard of.
Yeah. No, you scrub out in the middle of surgery, you run and pee. But interestingly, I don't know about you. If I'm doing a surgery, like I always make sure to, I'm weird. Like when it comes, like if I'm going on a car ride, I make sure to go pee beforehand. I'm exactly the same way with surgery. But then if I'm operating, it's very, very rare for me that I find that I have to scrub out to pee. And it's probably a mental thing because, right?
You're in your flow.
Right.
You
But
know?
then when you finish the case, you're like, oh, I have to pee, but you don't even realize it while you're doing the case, right?
Yeah, that's because we're focused on our patients and what we're doing. But yeah, no, absolutely. I think that is, a lot of women will come in and say, I'm okay all day long. But then when I get in bed, before I fall asleep, I get up like 3, 4, 5 times to go pee. I'm like, yeah, it's just an awareness thing. You just have nothing else to distract you from your bladder discomfort.
And what do you do for those people? Because you're just talking about me right now. What should I do? Do I need Botox or do I just need to, relax or snap out of it? What do I need to do?
Yeah, I mean, try to ignore it.
Okay. But I feel like I don't get as deep a sleep because of that,
Right.
Right? Do your patients say that?
Yeah, and then I give them vaginal estrogen cream.
So I need some vaginal estrogen cream. Okay,
I don't know
there
where
you
you're gonna
go.
put it.
That's the
Um,
answer. I don't know how. Okay.
Okay,
no,
so
but there's
that's another option. There's a cream you can have. It doesn't have to be like a Botox or a
well,
surgical thing.
okay, so now, sorry. So crossing over into kind of like bladder sensitivity,
Okay.
there are people have who are just really sensitive. So, but like if you eat, some people, if they eat spicy food or if they drink, something acidic or something carbonated, it really makes them need to pee more. I mean, it's normal. Everyone, like after you drink coffee, it makes you want to pee more. But there are some people who cannot, eat spicy foods. There's something called, we call it bladder pain syndrome or interstitial cystitis. And it's these patients who they feel as if they have a bladder infection almost. It can be that uncomfortable and, this inability to fall asleep. And so what we do is things to make the bladder more comfortable. So like if there's aloe vera, drinks or pills. And again, that's when the vaginal estrogen comes in because it can be soothing and calming and dietary modifications. But that's where also, breath work, Jason, maybe you should do some like deep breathing into your pelvic floor.
Hmm. But what are you saying about aloe vera? I didn't know about this. So aloe vera.
So if you drink aloe vera or take aloe vera pills, it, gets excreted through the kidneys into the urine, and then it actually coats the bladder and has like a soothing effect.
Huh.
Yeah.
Try aloe
But
vera.
as you
Yeah.
might know, it's also, used for constipation. So you have to be careful not to drink too much of it.
Nice. Yeah.
But the other thing that makes women like their bladder more sensitive and the frequency is menopause or perimenopause and decreased estrogen levels. So that menopause is like the huge topic everywhere now, but everyone thinks about hot flashes and the more typical symptoms, but there's also what we call genitourinary syndrome of menopause. So that is the effects that menopause has on the vagina and bladder. So, we have estrogen receptors everywhere throughout the body, and menopause and perimenopause is just a decline in the estrogen levels in our body, and the symptoms are the result of that. So in the vagina and bladder, it causes dryness, like vaginal dryness, painful sex, and then just bladder sensitivity. So back to like just that frequent urination, because whatever urine is sitting there is just causing discomfort and the urge to void.
So those women should take estrogen in what form? As like a
Vaginal
supplementary or
estrogen.
okay. Okay.
Yeah. So
Not estrogen patch or any that doesn't help.
the estrogen patch doesn't help as much with these symptoms. That they respond much better to the local estrogen that's put in the vagina. So there's a cream, there's tablets, there's a ring, so it comes in a variety of forms, but if it's put in the vagina, and then it treats the vagina and the bladder really well, and it's very safe and effective.
And it's a nightly thing kind of thing, treatment wise?
It's like twice a week.
Okay. And then do you also deal with like women's health in general or only specific to urogyne issues? Like I know some women are taking testosterone, postmenopausal. Is that something you do or treat or
Yeah, because of the kind of age range of women that come to me, there's a huge overlap with perimenopause and menopause. So I do, hormone health as well and hormone management. Um, Testosterone we use for libido. But a lot of women talk about using it for just for energy and muscle, and the doses required for that are not as safe. You're then getting into kind of like the male range, and their side
That's,
effects and risks.
this is the first I've ever heard of women using it for libido and like for energy. You guys both, I mean, Dr. Cohen, you heard of this? I guess it's more common than I thought.
Yeah, just in the aging population, part of like keeping young a little bit is one of the feelings that it's good to have testosterone for men and women a little bit, right? Have you heard that too? There's
That's
a
what I'm
run.
saying. Like, yes, that is something that is commonly done. Um, I stick to the lower doses, which probably aren't enough for, vitality and all those things. But it's what's safe to me, what's safe to use is kind of in that range that's to treat libido.
Hmm.
Okay.
What percentage of your practice is urologic versus sexual? Am I saying it right? Or bladder, GU
Oh,
versus sexual, or is that the
it
right way?
all pretty much goes hand in hand, but the majority of it is bladder.
Uh, got it.
Bladder, yeah.
Got it.
But then
What?
because I think women aren't really seeking out, it's the sex stuff is still taboo and they're not seeking it out as much. I then ask them about sex, and then we get into treating that as well, and the treatment goes hand in hand.
Do women get treated ever with Cialis or Viagra for sex and stuff like that?
So we can sometimes I'll compound a cream that has that topical sildenafil or whatever that so for vasodilation and to help with like clitoral stimulation, arousal, and whatever.
Is that common or not so common?
It's well, I don't think a lot of people offer that, but for women who have orgasmic dysfunction, that's a helpful treatment.
What about Lauren? What were you going to ask? Sorry.
No, I was just going to ask, is there some like common question or common thing that women come to you about that you wish more women spoke openly about, or that you want like maybe our audience to know about? Like, I mean, I feel like you've already told us a lot of things that I didn't know, so it's helpful. But I didn't know if
Yeah,
there
I
was
mean,
something else.
I think I could. All the things I treat in my practice fall under that umbrella of things that I wish women knew were
Mhm.
common and treatable. I think I really want to make sure that women know there are treatment options for them, because it still kind of blows my mind every day that women are like, yeah, I pee myself, and they just think it's part of getting older, part of life, or normal, or there's nothing that can be done. And
Yeah.
we have a whole like array of treatment options.
Yeah, I feel like women just aren't as open as men still. Like we have this like sex positive lifestyle now, but it's just like still like you have patients that you have to like pry it out of them. Like, what do they need? Kind of like, you can talk to me about this stuff.
Yeah, no, that's what I love most about what I do. It's, a
Yeah.
privilege that women will like open up to me and share things with me that they're, aren't comfortable talking to a lot of people about. And then hopefully I can help them if they're having issues. But yeah, I think for sure we're now learning from, the younger generation that they're so comfortable talking about their periods and all this stuff. And now clearly, so much talk about menopause and perimenopause and women's health, and it's fantastic. And also, it just has opened up the door for a lot of misinformation, and still some stuff is not touched on. So,
Do you find
yeah.
you have to like clarify sometimes? Like, I don't know if there's like TikTok influencers or people that are giving your patients bad information. Is that something you've encountered?
Yes. um, yeah, I'm trying to think what is,
Yeah,
what
what's
are
the biggest misconception or weird thing that's out, or wrong thing that's out there that you've encountered?
one thing that makes me a little crazy is these hormone pellets. So women love this first of all, this idea of like bioidentical hormones, and that just means it's identical to what we make in our own bodies, right? It's not synthetic. And the hormones that are FDA approved are also bioidentical, but I think women get this idea that if it's approved by the FDA, there's something wrong with it and they want something that's compounded. And it really should be the opposite, right? Because something that's being compounded, there's no regulation. You're really trusting that particular pharmacist to, be using the right concentration of everything, and who's checking those batches. And there's been shown to be variability from batch to batch, and people are making a lot of money off these things. But patients really strongly feel that that is a, safer and better way to go than what they can get covered by their insurance at their pharmacy. So the extension of that is now a lot of people do these pellets. So you'll go in, and instead of getting estrogen in a patch form is the typical way to use it for hormone replacement. But people will say, here, I'll inject you with 3 months worth of hormone, like a pellet into your butt, like butt cheek, not like up your butt. And I have patients who've gone and gotten testosterone pellets, and they come to me and they have, like facial hair and acne. And I don't understand why you wouldn't just use the cream or the gel or whatever. Why would you put 3 months worth of something in your body? So,
Wow.
Someone told them to. That's crazy.
some influencer told them to.
I'm surprised women are just like self-injecting testosterone. That's seriously.
Men too, though, right? Men are do that for testosterone too, supposedly, right?
Why do you keep asking me about men? I don't know what men do.
No, I have a patient who was getting that kind of
Yeah.
testosterone injection too, and I'm like, pellets,
Yeah.
and I'm like, I'd never even heard of that pellet.
I've never heard of it. I don't know.
Yeah, and I don't know. I mean, I don't even know enough I don't know what, like, the proponents of it. I would love to hear what is the advantage that they're saying of a pellet, just the convenience that you don't have to remember to take it daily.
Yeah.
Yeah. But then you're stuck with it.
Yeah.
If you
What are
have
your thoughts on alcohol and marijuana? Good, bad, doesn't affect things? Do you ever prescribe marijuana for any stuff?
Absolutely. So marijuana is also good for orgasmic dysfunction. Like, there's data on that. So we don't know which part, but yes, I think it's great for that. I think it's also great for pain. Women have pelvic pain associated with all sorts of different things. Yeah, I'm a proponent of the marijuana.
Do you work with Sherry Yafai, who's been a guest on our podcast before?
She has. I love Sherry.
Yeah.
Absolutely.
She's amazing. The Relief Institute. She's been a guest. I've worked with her.
Yeah. We work together a lot, and yes, that is who I send all my patients to, and I'll like madly text her and be like, wait, what do you recommend for this? Because that's a whole world of this type and that type. And
yeah. I wanted to know what teenage Rebecca thought she was going to be when she grew up.
Yeah, I wanted to get in that too. Like, how did you become a urogynecologist?
Yeah.
That is an excellent question. Teenage Rebecca, thought I was going to go work at the UN and be like a translator and do some cool like international stuff.
Where'd you grow up?
But what happened? I don't know. I really loved biology, and I shadowed a doctor at UCLA one summer, and I really loved it. And so that's
So that was the residency that you liked the most, like OBGYN, like that kind of sparked it, or how does it work?
I really always loved the idea of kind of, it sounds cheesy, but like empowering women by educating them about their bodies. I think I still almost every day, I'm giving my patients a hand mirror and giving them a little like orientation to their vulva and their vagina. Like a lot women who've had babies or, and don't really know what hole is where and what's what and what's the clitoris and what's the labia. Like it's, so I like it.
So when you went into OBGYN, you didn't go in thinking you were going to be someone delivering babies, or did you? And then, what?
I think I did. I mean, I wasn't thinking beyond the 4 years. I thought I would probably
Right.
do OBGYN, and then I didn't love OB, and I really like the idea of being more an expert in a finite amount of stuff rather than kind of, knowing less about a wider spectrum of things. And I don't know, to me, OBGYN is very, very, you know, 5 minutes you do a pap smear. It's I don't know, it's very primary care, and I don't know, I like doing what I do. I really feel like it, when you ask me if the surgeries are fun, it's pretty amazing to see, someone pre-op on the table with the uterus literally hanging outside their body, and then you reconstruct it and make it an innie again, or you do a 20-minute surgery and you treat their incontinence and they can go back to dancing or living their lives. So
That's great. Have you written a book yet?
no,
Are you planning on writing a book?
I don't know. What would it be about?
No, about you probably have amazing stories and anecdotes and women's health stuff. You haven't thought about that?
Yeah, I've thought about it, but like, do people really read those?
I don't know. People don't even read anymore, right? I
Right?
was talking to my mother-in-law the other day. She's like, "Do people even read anymore?"
Listen
I
to
don't know.
you? Oh, I don't know.
I love to read, but I'm stuck on my phone playing Candy Crush, so
I've
I don't know.
I've
Wait,
very
have you
written
written
that.
No,
you?
but I'm trying to work on it, but it's long and tedious and not happening yet. But
What would it be about, or what will it be about?
it's about more mentorship, because I created and run this pre-med program for like 12 years now. We've been doing it, and it ties into the podcast a little bit. So the podcast and the mentorship
I
that
didn't know that. That's very cool.
So we ask all of our guests. I guess we none of us really read anymore, so it might not be a book, but for a recommendation for something you're watching, maybe a TV show, a movie that you would recommend to our audience.
what you're consuming, whatever
Yeah,
it is these
in
days.
entertainment.
Okay. So I don't read, but I listen to audiobooks.
That'll work.
And so am I allowed to call that reading? I
Of course.
love, love, love a book that I read not too long ago called The Many Lives of Mama Love.
I don't know that one.
Really
Fiction,
nonfiction.
nonfiction.
Mm.
Tell us
It's
what it is.
this it's autobiographical, and it's about a woman who was like drug addicted and went into like served time in jail, and just this really amazing autobiographical story. And it's just really well, the author reads it herself, which I feel like makes a big difference if someone not good is reading the book. So yeah, listen to that. That's a good one.
The Many Lives of Mama Love.
Yeah.
I just have a quick question. Do you
One
think?
more quick question.
Well, I
Okay.
was just wondering, do people have like, is there a long wait to see you? Because I've never heard of a urogynecologist before, and I was wondering if like more women are needed in the practice, like that type of thing.
I mean, I do think that more women, we need more people going
Okay.
into the field in general, for sure. The beauty of I don't have a long wait because I'm not contracted with insurances, so I get
Okay.
patients in pretty quickly.
Nice.
Your
Okay.
concierge.
Yeah.
Yeah. Wait, you made me think of a question too, but it just went out of my brain. Oh, how many urogynecologists are men versus women? What percent? Like, if I were a woman, I would not want to go to a male urogynecologist.
Yeah, I
Me,
agree. I think it's hard. I think, I always say when I was an intern, uh, and this is just for OBGYN residency, 3/4 of the senior class were male. And then by the time I graduated, it had flipped. And now I think, just men going into OBGYN in general is I don't know what the percentage is, but it's pretty small.
Right.
But then of those, a lot of them do go into the more surgical specialties. So
Right. So do you see men doing Urogyne or not really?
yeah.
You
Hmm.
do? I'm trying to think of, maybe I know a few. I'm not even sure.
Yeah.
Well, Dr. Rebecca Lane, you're amazing. Thank you for joining us. It really made my day to be able to say hello to you and talk to you. And I'm going to bug you a little bit after we cancel this, after we stop the recording. But thanks, everybody. Thanks for listening. And anything else?
no, thank you. Thanks for talking about women's health. I appreciate it. I learned a lot.
You know what? Thanks for having me. I love talking about this stuff, and I'm glad that you guys are, have this platform and are using it to share this information with women. So thanks.
That's it for this week. Thanks for listening to Gross Anatomy, and be sure to subscribe to our podcast so you can check out more episodes on the evolving sights, smells, and sounds of medicine. Gross Anatomy is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition.